So BLAST-1 was an investigator-initiated trial that I led in muscle-invasive bladder cancer, where we treated patients with the chemotherapy and nivolumab, followed by radical cystectomy, and we saw about 66% pathologic downstaging. And now we wanted to see, we've looked at biomarkers of response and resistance in that, but we wanted to see how we can incorporate artificial intelligence at predicting responses, looking at H&E slides, digital pathology, and we collaborated with this really great team at Emory to look at our pre and post tumor slides. And they looked at the H&E and the nuclear segmentation and fragmentation, and based on the models they have already validated in a lot of different tumors, they use training sets and validation sets for this, and they found that their model can independently predict pathologic downstaging, just looking at H&E slides. So that is really a good step forward in our understanding, because if, let's say, based on baseline tissues, we can try to get a sense of which patients may not actually respond to treatment, then we can spare unnecessary treatment. And this model also correlated with the TCGA data set. So this is really exciting. And we also used another data set from our metastatic bladder cancer patients in our single institutional patients treated with any immunotherapy, where we looked at the H&E slides and they looked at TILs and the nuclear segmentation, and also were able to predict which patients may respond to immunotherapy. So this is early data, but this is really very thought-provoking, and we want to take it further. So I think, we also have a grant looking at neoadjuvant setting with chemoimmunotherapy, chemotherapy, and immunotherapy separately and AI is built into those to look at biomarkers of response and resistance. So I think once we get some good signals, then for other prospective trials, we can use this as an endpoint. And ultimately, the vision would be to look at somebody's histopathology slides and genomics and be able to tell, okay, this patient is not going to respond to chemotherapy or immunotherapy, or this patient is going to respond to these treatments. And I think for that, we'll need some larger validation studies. So this is a good step in the right direction. So for patients with muscle-invasive bladder cancer, historically, the gold standard has been neoadjuvant cisplatin-based chemotherapy followed by radical cystectomy. But we know that a lot of patients are not eligible for that or eligible for cystectomy, and a lot of patients don't want cystectomy. So bladder preservation is really a big unmet need that we need to do more of. And we know that chemoradiation or CRT is effective in bladder cancer. And this trial is just pushing the envelope to see if addition of pembrolizumab will add to the benefit of CRT. So this is a phase 3 trial of around 636 patients who will be randomized to chemoradiation and placebo versus chemoradiation and pembrolizumab for 9 cycles. And of course, they'll undergo routine cystoscopies and biopsies when needed. Primary endpoint is bladder intact disease-free survival. And secondary endpoints are, of course, PFS and OS. And I think there's scientific rationale to believe that immunotherapy and radiation can work together and have additive synergy effect. And we'll see more from this trial if this will improve outcomes for patients who choose for bladder preservation. So that's really a great question. So Javelin Bladder 100 trial was the trial that set avelumab maintenance as a standard of care, because in patients who got frontline platinums and did not progress, when they were randomized to avelumab maintenance versus best supportive care, avelumab maintenance improved overall survival by about 7 months. But we saw that in the subgroup analysis, patients who have visceral metastases didn't do as well as those who had only lymph node metastases, for example. So there was scope to intensify this maintenance strategy, because we really want the frontline treatment paradigm to be most effective so that we don't lose patients later on. So that's where this trial was born, so to speak. So in this, the control arm is avelumab, not best supportive care, and the treatment arm is avelumab and cabozantinib. which we know that there's a lot of scientific rationale to combine a VEGF TKI with immunotherapy, and our primary endpoint is overall survival. Key differences from Javelin are we are limiting the treatment to 2 years, and we're using flat dose avelumab. We are also including M3 only patients initially. So this trial is just, building on the backbone of Javelin and seeing if we can further improve outcomes of patients with this maintenance approach who historically just with immunotherapy didn't achieve that much benefit. So this trial is a cooperative group trial out of the Alliance group, and it's actively enrolling in the US, and it's also endorsed by the Canadian Clinical Trials Group, and they are actively enrolling. So this is an exciting trial, and we hope to make some changes to fit in with the current paradigm and change the primary endpoint from overall survival to progression-free survival, so we can decrease the number needed to complete this trial. So as a background, we first defined the platinum ineligibility criteria in the US a couple of years ago. We surveyed about 60 genitourinary medical oncologists and asked them a variety of questions around what thresholds of performance status, creatinine clearance, heart failure, peripheral neuropathy would they consider as somebody not to give carboplatin to. We already knew cisplatin ineligibility from the Galsky criteria. This was an effort to define platinum ineligible patients. And we presented those at ASCO last year. And we also wanted to take this a step further and see in Europe what are the physician perceptions. And we interviewed a much larger cohort of European physicians in 5 countries. Around 500 physicians were asked the same questions that we had defined earlier. And we found that the responses were very consistent with the criteria, like ECOG performance status greater than or equal to 3, creatinine clearance less than 30, NYHA heart failure greater than 3. And in the US group, we did not find age as a criteria for denying somebody platinum. Specifically, we asked the question of different age thresholds. But in Europe, interestingly, over 67% doctors would not offer carboplatin if a patient was above 80 years of age. So that was something we found it was different in the European survey. And that is probably one of the reasons why there may be underutilization of platinums in many countries, if the physician's perceptions are to think of age as a limiting criteria. So I think this is important work because in the US, we don't really use that as a criteria. But I'm sure many people in practice use that. And in the group that we had interviewed, that was not felt to be a criteria. It's not because, all these trials, they don't have an age barrier, right? Even in the Javelin Bladder 100 trial, there are patients above 80. All these metastatic urothelial cancer patients have patients age above 80. The median age is 71 years, so we have these patients. So I think it is important to address this as a barrier to prescription of platinum chemotherapy and do some, education around it, that age necessarily by itself does not need to be a barrier. So it's an opportunity to guide physicians about not using just age as a barrier, but looking at the patient as a whole. Because you may have some really fit 80-year-olds and, really unfit 45-year-olds. So I think that's the message around this.